Okay, so all three talks are open for questions. Charles, why don't you come up? And we'll have specific questions related to these three talks, and please state who you're addressing the question to. And then after we have a few of these questions, then we will get to the public comments in about 15 minutes.
So I'm Lynn Goldman, George Washington University. Last talk was particularly stimulating, one might say. I was wondering, in particular, when we're thinking about adolescents and young adults and their behavior, and one of the things that occurred to me is that a driver for them for both of the behaviors that you were talking about, and that is the caffeine use and also the use of these non-prescription drugs, is the availability of resources in order to be able to acquire those things, and whether you were able to look at that as a variable, and that is the ability, purchasing power that these young adults had. I mean, is it possible that by coincidence the same individuals who have the ability to buy these drinks also have the ability to acquire these non-prescription drugs, which I'm assuming they're prescription drugs that were not prescribed to them. I'm assuming they're acquiring them from others. You're talking about things like acquiring Ritalin or acquiring...
Right, exactly.
Yeah.
We've done a lot of work on the non-medical use of prescription stimulants, their availability, their access, the methods of obtaining them. And by and large, students obtain them for free from a friend or a relative or an acquaintance that has a prescription. And they are widely accessible. And the nice thing about our study is that they all had similar access. I mean, one thing that we could look at is we've measured the access to the drugs, and we can look at whether or not the energy drink users were more or less likely to have access. But I think because they all came from the same campus, that would be pretty unlikely, and the rates of access of these drugs, they're widely available. Yeah, good question though.
Dr. John Higgins, University of Texas Health and Memorial Hermann Harris Health, and excellent presentations from everyone. My question is for Dr. Area. Dr. Area, what was the typical pattern in the individuals that you followed? For example, were they consuming energy beverages and then they kind of needed more of a buzz, so now they are consuming more energy beverages, for example, instead of one dose, maybe 2 doses, and then in the next year they substitute those analgesics or others for kind of a buzz now that they are no longer getting, or are they simultaneously having both the energy beverage and the analgesics, etc.? That was my first question. And then my second question was there any sex difference between males and females in your study?
Let me answer the second question first. We controlled for sex in that study that I showed you. What we have found is that there's a gender difference with respect to energy drink use. And interestingly, we have a higher proportion of girls drinking coffee and boys drinking energy drinks. But let me go back to your first question. It's an interesting idea. How much they are consuming might be related to their likelihood to try something with greater potency. We found pretty similar dose and frequency of energy drink use, higher prevalence overall. Like I said, we had a 65% annual increase from year 2 to year 3, but in this study we only looked at year 2. And what's interesting about your question is we did not find that. So we didn't find like an increase in the energy drink use leading people to, we didn't examine that. We looked at whether or not they were a user and whether or not non-medical prescription stimulant use came on board in year 3. What's interesting about your question is that Woolsey et al. Has a paper in press. I'm not sure, I think it's available. Brittany is in the audience and she could tell you whether it's available. I've read it, so it must be online somewhere. And he found a great overlap between the substitution of energy drinks and the use of non-medical prescription stimulants for studying. So he found a substitution effect when they couldn't find energy drinks, they could find non-medical prescription stimulants. So, and he also found, interestingly enough, I'll just use the time to tell you this, he was looking at ADHD positive students in his study as well, in addition to non-ADHD, and he found that every single person who had a prescribed ADHD medication was using energy drinks. 100% of his ADHD positives were using energy drinks. And I think that calls into question whether or not somebody needs to be looking at the interaction of energy drinks with prescription stimulant medication. Sorry for the long-winded response, but.
No, that's very interesting.
Question. John, can we have somebody else, and you can go to the back of the line?
Yeah, sure.
Phil Saul from Charleston. I guess one question for you, Dr. Aria, was a follow-up on what you just said. Since they do have very similar psychological effects, do you think your study just means that they were substituting the stimulants for the caffeine? Since, I mean, a lot of people with ADHD self-medicate with caffeine for the same feeling.
Yeah, we have the data on motives. We have not had the resources to analyze it. We could look at that. I think the health implication is that the non-medical use of prescription stimulants without a physician's with advice or consultation is a risky behavior. And it's not something that we encourage. We've written policy papers on how to, if you have symptoms of ADHD, go see a doctor. You know, don't do it on your own.
Oh, absolutely.
So we don't really want kids to be substituting a legally available thing for something that's not legally available that could have possible contraindications, especially in people that are vulnerable.
Sure, it's the question of gateway versus usage. But I had a question for you, Dr. Griffiths, as well. Since I'm somebody who withdraws from caffeine and recognizes it and does some and gradually withdraws, but how do you account in the tolerance withdrawal addiction scenario? How do you account for the fact that so many of us self-regulate caffeine, even though we like it in some way? We also know when we've had too much and back off and do withdraw and other things like that. Where do you put that in the mix?
Well, I mean, caffeine's a great drug, and it's ubiquitously available in our culture. So, in fact, it doesn't pose a problem for people who don't have adverse reactions to caffeine and can readily afford and defend their access to caffeine. So I don't think there's anything to reconcile there. I just want to make one comment on Chuck's presentation, because I just don't want to leave the impression that there's much light between us. Let's see. Number one is that your study isn't the only one that withdrew people under conditions where they weren't informed. Our New England Journal paper did that. Other studies have done that.
Didn't they know they were in a
They
dependent
didn't.
study?
No, absolutely not. No, all they knew is they were in a study that had to do with dietary supplements. And so they had no information. We gave them all kinds of bogus directions about shellfish and and NutraSweet and stuff like that. So they didn't know that this was about caffeine. So that's number one. And number two is, I mean, even if we take it that your estimate, so from our major review, we estimated the incident of significant functional impairment was 13%. You're showing 2.6%. I mean, even if it's 2.6%, that's not trivial, in a population in which caffeine is consumed by 85% of the group. I mean, 2.6% of our population is something to pay attention to. But I suspect it's going to be significantly higher than that. But whether it's 2.6 or 5 or 10, doesn't matter.
Chuck, you want to respond, and then we'll get another question.
I think that people self-select for studies like this. And so the population that we were studying had no idea that we were interested in caffeine withdrawal. read the New England Journal paper, and I thought it was focused on caffeine withdrawal, but maybe I forgot because it was a long time ago. But the fact is that these people, all of the ones that we selected, said they would have caffeine withdrawal. You know, they had self-identified as being characteristic, just like the gentleman who recently asked the question. But I wonder if he would recognize the withdrawal if he wasn't looking for it. And you see, I've had so much experience in doing placebo-controlled studies where I've been astounded by how powerful placebos are. Whatever I put in the consent form, the placebo patients show. Some of them do. And you can see that in the PDR. You know, so the placebo group for everything has some of the same symptoms that we report for caffeine withdrawal, especially headache, tiredness, difficulty with energy, and so forth. I mean, these are vague things that, to some extent, people have every day. And if they've signed a consent form, some of them are going to report that, and that's the issue. But on the other hand, if you get people who identify that they've got a problem, and especially because doctors have told them they have to stop drinking coffee, and they can't stop, you know, that's an issue too. I mean, we've had patients who say they can't stop one drug or another, and then we try to get them into a double-blind study and find out that if they don't know we're decreasing the dose, they can stop a lot better with a lot fewer symptoms. So, I'm just emphasizing the placebo effect.
I have a question to Dr. Aria. I read your study a ways back.
Identify yourself, please.
My name is Dr. Michael Foreman. I'm an emergency physician in clinical practice. And my understanding is that you sent a survey out to students at a college, correct? And you asked if,
No, we didn't send out the survey.
You surveyed students at a college?
We have been doing face-to-face interviews with our students since the beginning of their freshman year. So we had them come in and do face-to-face interviews.
Okay, apologize. Now, risk-taking behavior was defined in your study, and I don't remember all the various things, but I do remember unprotected sex. Is that?
No, that was the Miller study.
Oh, okay.
Yeah, when I focused on our study because the risk-taking behavior of interest was subsequent use of an illicit drug in year 3.
Okay, so I guess what I'm asking is, are you suggesting that energy drinks are causative of risk-taking behavior, or that you're identifying a demographic of students who like energy drinks and who also happen to take part in a disproportionate number of risky behaviors?
I think what the new public health model is trying to do is understand the relative contribution of a risk factor to an outcome in a prospective design where you control for as many confounders as you can. And over time, science will be self-correcting. You need multiple studies to determine whether or not there's evidence of causality. So no one study can get at causality. It takes an accumulation of evidence, and the evidence has to come from studies that attempt to evaluate the contributory role in multivariate explanatory models using the best statistical techniques possible. And so our study was really the first in what we hope to be a series of prospective investigations that try to determine that contribution of energy drinks to future new illicit drug use.
So would it be accurate to say that at this point there is no strong evidence that energy drinks are causative of risk-taking behavior, that you don't have that?
Of course not. Of course not. I think that the absence of causality means that there is the lack of evidence of safety. And I think the burden of proof on whether or not regulations need to occur is really on the demonstration of safety rather than on the demonstration of causality.
So that could be literally applied to any product, that you have to prove every single product.
Oh, exactly. Oh, that's why we have the FDA. I think it's wonderful. We live in the best country in the world for having the FDA that has to demonstrate safety of their product before introduction to the market.
Right, but you're talking about a behavioral issue, not a medical issue per se. You're
Oh, I think use of drugs and problems that occur because of drug use is a medical issue.
okay. Well, I guess what you're saying then is at this time there is no demonstration of causation, energy drinks to risk-taking behavior, but there may be in the future. I'm just trying to clarify.
I think that there's strong data to suggest, and very compelling data, very consistent across studies to demonstrate a contributory association, and that yes, we need more studies to demonstrate in whole causality.
My last question, then what, just last
Can we move on?
Just wondered if you could, what would be
One more.
the theory behind the contents of an energy drink causing this effect?
The theory,
Yes. You must have a hypothesis of what in an energy drink would cause an
I
association.
think that the data that I presented on the neurodevelopment of the adolescent brain serves as my conceptual framework for why an adolescent in his early years would be more likely to use in a subsequent way an illicit drug after being exposed to a psychostimulant like caffeine early on. That's my theoretical framework.
Thank you.
Hi, I'm Dr. Davis, University. What about just Starbucks?
We controlled for other types of caffeine consumption in our data.
What about
And
Starbucks causing the progression? My
we
students-
haven't found until, we look at other types of coffee and we just don't find the association with coffee consumption. We measure coffee, tea, soda, and we just don't find these associations with risk-taking behavior.
All right. Thank you for everyone for this session, and we'll go on to the public comments for people that have signed up first. And Lynn, you have the mic.
Okay, so I want to just thank everybody for really what was a wonderful round of presentations, but also questions. A little bit of heat, I think, but a lot of light, and I think that's what we're here to do, to help shed light on these issues. We now have a period for brief public comments from stakeholders. I have a list, and we're going to call you up here alphabetically. And so don't sit down too quickly, Dr. Adamson, because you're the A person, so you're going to be the first. And I just should say that we are scheduling 3 minutes for each presentation. And I'm told that at 3 minutes, not only will the light change, but there will also be a sound that will emanate from the timing system that...
Lynn, I'll reserve
There will be
mine for tomorrow.
What?
I'll reserve mine for tomorrow.
You'll reserve yours for tomorrow? I don't know if we don't have a public comment session tomorrow, so if you would rather go last in deference to the fact that you've been sitting up here, we could take you last if that's okay.
That's fine.
All right, so the first shall be the last or something. But I will say that the sound, if it's an annoying sound, I apologize for that in advance. So there'll be a yellow light at 1 minute, and then when your 3 minutes is up, there will be this sound. And so I would like to invite, it says it'll either be Dr. Bob Ornott or Dr. Michael Foreman from the Monster Energy Company, if you could come forward.